The good news is we have about 24 of these therapies to choose from. The bad news is we have about 24 of these therapies to choose from. And there isn't a one best one. There isn't a one right one. This is a very individualized approach that should be done as part of a shared decision-making process between the person with MS and the healthcare provider. And it's very nuanced.
The number of disease-modifying therapies approved for MS continues to grow. So, with more than 20 choices of high-efficacy and more moderately effective DMTs available, how do you and your neurologist identify the best treatment for you? In a moment, we'll meet my guest, Dr. Barbara Giesser, who weighs in with thoughts about how shared decision-making, when done right, can lead to the right disease-modifying therapy for you. Dr. Barbara Giesser is a neurologist at the Pacific Neuroscience Institute. She's an internationally recognized clinician and award-winning educator specializing in the care of people with multiple sclerosis since 1982. Dr. Giesser has received a dozen awards for excellence in education at the local, regional, and national levels, and is the author of over 100 publications, including peer-reviewed research articles, reviews, textbooks, chapters, and abstracts. In fact, she served as the editor of the Primer on Multiple Sclerosis. That's the reference book that thousands of healthcare professionals rely on to better understand how to best treat MS. Welcome back to the podcast, Dr. Giesser.
Good morning, John. I'm so happy to have the opportunity to talk to you. Thank you. I will say parenthetically, I don't know about the reference, but I appreciate the shout out.
So, we're talking about disease-modifying therapies, and with more than 20 DMTs approved to treat MS, how do you choose one?
It's a great question. And again, I'm so happy that you brought this up as a topic for conversation. As you noted, I've been doing this a very long time. And when I started in the MS field, we did not have any disease-modifying therapies. We had steroids, and that was about it. So when the very first disease-modifying therapy, beta interferon, was approved in 1993, it was really a sea change. And for the first time in the, long recorded history of MS, we were able to tell people with MS, we have something that can control this process. We can't cure it. We can't shut it down completely. But, the disease is no longer going to want to do what it wants. And in some respects, in the early days of disease-modifying therapy, it was a little easier. We only had a couple to choose from, and they were all fairly equivalent in safety and efficacy. And I don't know that it made a big difference. So now what I sometimes tell people is the good news is we have about 24 of these therapies to choose from. The bad news is we have about 24 of these therapies to choose from. And there isn't a one best one. There isn't a one right one. This is a very individualized approach that should be done as part of a shared decision-making process between the person with MS and the healthcare provider. And it's very nuanced. What we have learned over the past 30-odd years, we used to take an escalation approach. So as we began to acquire more agents, and some seemed to be more effective than others, but the more effective ones generally had a little more of a side effect profile, we would say, well, let's start you on perhaps a less efficacious but safer agent. And many patients did well on that. And if they didn't, if they had either breakthrough clinical relapses or activity on the MRI, we could say, okay, let's escalate. And what we now think we know is that people who are started earlier on a more effective or a more aggressive therapy, if you will, tend to have better outcomes down the line. So this is one guideline, if you will, not an absolute, but one guideline, especially when we are dealing with newly diagnosed or treatment-naive patients. We may tend to want to put them on a more effective agent from the get-go. Other considerations that would steer us toward putting somebody on a more aggressive agent would be if they've had a lot of relapses, if they have a lot of inflammatory activity, if they have spinal cord lesions. Those are things that tend to suggest we really got to hit this thing hard.
We often talk about the value of shared decision-making between a patient and their doctor on this podcast. So I'll pose that same question from the patient's perspective. With more than 20 disease-modifying therapies approved to treat MS, how does a patient educate themselves enough so that they're ready to make an informed decision about their DMT with their neurologist?
That's a great question. And what I loved you said about being informed and being educated. There used to be an ad for an old clothing store, and the ad for the clothing store was an informed consumer is our best customer. And I think an informed patient is the patient that's best equipped to manage their MS. So I would think that the education certainly starts with the healthcare provider. I think it is the responsibility of the healthcare provider to provide the person with MS with education in the office, education coming directly from the healthcare provider, and other resources that the person with MS can go to. The National MS Society, for example, has all the disease-modifying therapies listed on their website. Each of the different disease-modifying therapies has a website. And while you take into account that some of that, may be marketing material, they do provide the facts. So I think the education process begins with the healthcare provider, and there may be some additional resources the patient can access as well. I think the other nice thing about starting the education process in the office is obviously the person with MS has the opportunity to ask questions, i.e., well, you said this drug can cause that side effect. Can you tell me a little more about it?
A very common patient complaint is, I don't feel any better. Why isn't my DMT working? So first, I'll let you answer that question, and then I'd like to hear your thoughts about how we might be able to avoid that question altogether.
And again, I have a little perspective, having done this for a while. And when the first DMT came out, they had interferon. It was injectable. And we would say to patients, okay, you're going to have to give yourself a shot several times a week or every day, and you may have some side effects from it, and it's not going to make anything better. And they would look at us in horror. So I think you have to begin any conversation about disease-modifying therapy, which to state clearly from the outset, these are preventative agents. Right now, we don't quite have the capacity to reverse damage. We don't have the capacity for repair. That's going to be the next generation of treatments. But right now, we can stop or retard disease progression. And so I think if the person with MS starts out from that perspective, they're a little better prepared to know what to expect.
Consider this hypothetical scenario. We're in a neurologist's office. The patient is there. They're having a conversation about disease-modifying therapies, and maybe that neurologist has not necessarily been keeping up with the current literature. They have a busy schedule, and so they recommend Copaxone because it's something they've recommended for a very long time. Now, that newly diagnosed patient has done a bit of research, or at the very least, they've caught the TV commercial, and they're interested in starting Ocrevus. What should the ensuing conversation between the patient and that neurologist be like?
Again, and I go back to the statement that there isn't a one best drug. Of all we have about 24 disease-modifying therapies. We don't have 24 different mechanism of actions because there are certain drugs in a class. There are like 2 or 3 different brands of the same class. So if you go by mechanism of action, we have about 10 or 11 different classes, different mechanisms of action. And of the disease-modifying therapies, we kind of semi-arbitrarily divide them into low efficacy, medium efficacy, and higher efficacy based on their effects. So what do you mean by high efficacy? Well, higher efficacy drugs are those that have a more pronounced effect on decreasing relapses and decreasing inflammation. Those are 2 of the main outcome measures in most of the clinical trials. There are others, of course. So Copaxone is in our low efficacy tier. and Ocrevus would be one of the drugs in the high efficacy tier. And I think the conversation should be the relative efficacies and side effect profiles of those drugs, and also what the individual clinical situation of the patient is. And as I say, I think most MSologists, if you will, based on studies, would be more inclined to start somebody on a high efficacy drug. Now, again, there are obviously individual considerations. And if you had a patient who, for whatever reason, you thought perhaps might not be able to tolerate the potential side effects of a higher efficacy drug, you might have to go to a safer or lower efficacy drug because of that. But as I say, it's nuanced.
I heard you start to answer this question a moment ago, but it's an important one. So I think it's worth kind of focusing on for a moment. You mentioned that an informed patient is the best kind of patient. Today, people find a lot of information and go on to make important life decisions based upon what they read or see posted on social media sites. Is that a good place to look for information on disease-modifying therapies or really any aspect of your treatment?
Certainly, and this is a cliche, but the internet is, of course, a double-edged sword. You can get all kinds of terrific information on it, and you can get a lot of really scary out there information. I don't go on social media, and I'm not really familiar with a lot of what goes on out there. I think in terms of using the internet, you want to go to a vetted, for want of a better word, legitimate website, again, like the National MS Society. My scientist friends tell me that the plural of anecdote is not data. So if somebody is posting anecdotal information, I think you have to take that for what it is. I think people can certainly share experiences, and it may be helpful for somebody who has some trepidation about a disease-modifying agent to read somebody's post. Oh, I started taking, whatever disease-modifying therapy, and these are the side effects I had initially, but now I'm doing fine. Or I'm taking X disease-modifying therapy, and these are some of the ways I deal with the side effects. But in terms of objective data, in terms of efficacy and safety and things like that, I don't know that anecdotes are the best source.
If a patient feels like they're just not being heard by their treating neurologist, what can they say that might change things? A healthcare provider we're only as good as the information we get. So if a person with MS is having a side effect or doesn't understand something we're not going to know unless they tell us. And I always feel badly when a patient thinks that they're not being heard. So, sometimes you just have to be forthcoming and say, I don't understand why this is happening, or can you explain to me why we are doing this? Or I read that this drug can cause this side effect. Neurologists, for the most part, we're reasonably smart, but we're not mind readers, and you have to tell us what's on your mind. Well, Dr. Barbara Giesser, I want to thank you for all you do to improve the lives of people living with MS, and thanks so much for talking with me today.
And I'd like to thank you for all you do to improve the lives of people with MS by giving them information. And thank you very much for inviting me to be a guest on your podcast.